Tubal ectopic pregnancy diagnosis. This teaching video is meant for undergraduate medical students. The second useful test in the evaluation of suspected ectopic pregnancies is the measurement of serum human chorionic gonadotropin. A negative HCG result excludes pregnancy, that is either an ectopic or an intrauterine pregnancy. A serum beta HCG level less than 5 milli international units per ml is negative for a pregnancy, excludes pregnancy. If the level is more than 25 milli international units per ml, it confirms pregnancy, but it may be either intrauterine or ectopic. An HCG level between 6 and 24 ml per ml is a gray area. You need to retest to see if the levels rise to confirm or exclude a pregnancy. What is the discriminatory HCG level? Currently, it is considered as a level more than 3500 milli international units. What is the significance? If the serum beta HCG level is above the discriminatory level, then an intrauterine gestational sac should be visible on transvaginal ultrasonography. But mind you, not transabdominal, but transvaginal. Absence of a gestational sac on transvaginal examination in the presence of HCG measurement above the discriminatory level, that is more than 3500 milli international units. Then you have to think of two probabilities. One, an early pregnancy loss, or two, an ectopic pregnancy. In early pregnancy, beta HCG levels in the serum increase rapidly. It may reach up to 100,000 ml by 10 weeks of gestation. Serum beta HCG levels doubles every 48 hours. The rate of increase in beta HCG in 48 hours varies according to the initial HCG level in the blood. If it is less than 1500, the increase in beta HCG would be by 50% minimum. If the level is between 1500 and 3000, then you would expect a minimum of 40% increase in the serum beta HCG level. And if the level is more than 3000, the minimum increase is around 33%. 99% of normal intrauterine pregnancies will have a rate of increase faster than this minimum. If the increase in serum HCG is less than this anticipated value, consider abnormal pregnancy. It could be either an ectopic or early pregnancy loss. Women with early pregnancy loss, 95% have a decrease in HCG concentration of 20 to 35% in 48 hours, depending on the initial HCG levels. These patients should be monitored until non-pregnant levels are reached, because rupture of an ectopic pregnancy can occur while levels are decreasing or are very low. How will you manage a hemodynamically stable patient in whom a diagnosis of ectopic pregnancy or intrauterine pregnancy cannot be made based on the initial transvaginal ultrasound and serum HCG? This is a common clinical situation. For example, a primee with a positive urine pregnancy test. The transvaginal ultrasound does not show an intrauterine pregnancy, and the serum HCG level is less than 3500 milli international units per ml. In such a clinical situation, you make a diagnosis of pregnancy of unknown location. What you need to do is repeat the ultrasound as clinically indicated within 2 to 7 days and repeat the HCG in 48 hours. In almost 100% of normal intrauterine pregnancies, the HCG levels rise by at least 35% within 2 days. If the HCG rises less than 35% within 48 hours, consider one of these probabilities. It could be a normal intrauterine pregnancy. If that is so, it will show up in a repeat ultrasound. It could be an abnormal intrauterine pregnancy. The repeat ultrasound again may not show an intrauterine pregnancy. It could be an abortion, either complete or incomplete, or for an ectopic pregnancy which has undergone abortion, tubal abortion, or an ectopic which has spontaneously resolved.